Welcome to this clinical walkthrough on the obsessive compulsive disorder case for UCAMLA, brought to you by Mediate, your 24/7 practice partner. All right, so here's what we're going to cover in this breakdown. We'll start with how to kick off the consultation, then get into the nitty-gritty of taking a focused history. After that, we'll look at the bigger picture, talk about how to deliver the diagnosis, create a solid management plan, and finally, wrap everything up with proper safety netting and follow-up. Okay, let's dive right in. You know, the first few moments of any consultation are absolutely critical. This is where you set the tone, build rapport, and create a safe space where your patient feels they can actually open up. This opening script, it's gold. You're confirming who they are, you're showing empathy by acknowledging their struggle, and then you're asking for their consent to continue. With just a few short sentences, you're ticking all the key communication boxes for your OSCE right from the start. So you've set the stage, now it's time to get into the real detective work, taking a precise and focused history to truly understand what's going on with your patient. So you don't want to jump straight in with specific OCD questions. That can feel a bit intense. Start broad. First, get the patient to describe their anxiety. Use open-ended questions like, can you tell me a bit more about this feeling of anxiety? Or what kind of things go through your mind when you feel that way? This gives you some really essential context before you start to narrow things down. Okay, once you've got that general feel for their anxiety, then you can start screening for obsessions. You've got to use clear, simple language here, no clinical jargon. A direct question like the one on the screen is perfect because it's so easy for a patient to understand. You can then follow up by asking if those thoughts feel intrusive or like they can't control them. Next up, you're looking for the compulsions. And the key here is to connect the dots between their actions and their thoughts. You're looking for that classic cycle. An intrusive thought creates anxiety, and then a specific action is performed to try and relieve that anxiety. That pattern, that's the hallmark of OCD. And here's a great way to phrase that. You're directly linking the feeling of anxiety to the urge to act. And then, by offering a specific example like hand washing or checking things, you're giving them a huge clue. It can help the patient recognize their own compulsive behaviors, which, believe it or not, they might not have even labeled as such themselves. Okay, so you've identified the core symptoms. Now it's time to zoom out a bit. We need to see the bigger picture, how this is affecting their life, screen for any other issues, and most importantly, check for any immediate risks. You need to figure out how much this is actually impacting their day-to-day life. This helps you gauge how severe it is. Ask direct questions. How much of your day would you say is taken up by these thoughts and actions? And is this getting in the way of your studies or your work? That's a huge piece of the puzzle. Next, think of this as your quick psychiatric systems review. You need to screen for coexisting depression by asking about their mood, their sleep, and their energy levels. And also, you have to assess their insight. Asking if they feel their thoughts are excessive helps you understand if they know the thoughts are irrational, which is a classic feature of OCD. This one is completely non-negotiable. You must ask about self-harm and suicide risk in every single mental health consultation. And remember, asking directly does not put the idea in someone's head. It does the opposite. It creates a safe space for them to talk about it. It's also important to know that for patients with OCD, these can sometimes be intrusive thoughts of harm that they find deeply upsetting, which is different from active suicidal intent. Your question gives them permission to talk about this without fear. So, you've gathered all your clues. Now it's time to put it all together and present your provisional diagnosis. This is a moment that calls for both clarity and a whole lot of compassion. The key here is your delivery, calm, confident, and clear. Using framing language like, from what you've told me, shows that you've been listening and that your diagnosis is based on their story. Stating the full name and then the acronym, OCD, helps to demystify the term for them. As soon as you say the words OCD, your very next sentence has to be a simple explanation of what it is. No jargon, break it down for them. Unwanted thoughts, which we call obsessions, create anxiety, and those lead to actions or compulsions that are done to try and reduce that anxiety. And always, always reassure them that it is a recognized, treatable medical condition and that their distress is very real. Remember, a diagnosis isn't the finish line. It's the starting point. The next step is to build a management plan, and you have to do this with your patient. Frame it as a team effort, something you'll work on together. Present the plan in clear, structured steps. Think of it in 3 main parts. First, psychological therapy, and you want to be specific. CBT with something called exposure and response prevention is the gold standard. Second, medication, usually an SSRI. And third, psychoeducation and self-help resources. When you talk about medication, you've got to be specific. For fluoxetine, which is first line, You need to mention the starting dose, the fact that it can take 10 to 12 weeks to see the full effect, and the common side effects. And here's the critical part. You must warn the patient that their anxiety might actually feel worse for the first week or two. Managing that expectation is vital if they're going to stick with it. Look, hearing all this is great, but doing it under the pressure of an OSCE is a whole different ballgame. You can practice this exact case right now and get objective feedback on mymediate.com. Okay, we're on the home stretch now. And honestly, this last part, safety netting and follow-up, is one of the most important things you will do. It makes sure the patient leaves feeling supported and knowing exactly what to do if things get worse. So here's your safety netting checklist. These are the things you absolutely have to tell the patient before they walk out the door. First, book a specific follow-up, especially if you're starting meds. Tell them exactly when to come back if things get worse. Give them concrete resources for a crisis, like a mental health line. And finally, explain what would need to happen for you to escalate their care to a specialist team. And there you have it, a full walkthrough of an OCD consultation. To make all of this second nature for your UKMLA, practice is everything. You can practice this exact case now on mymediate.com.